I think the work that is being done by AAKP is so critical to patients all around the country. Their ability to advocate on our behalf ensures that everybody understands the impact of kidney disease and what they can do to help us.
Now everybody is fully understanding that to achieve a better quality of life, you really need to listen and take into consideration what the patient views as a better quality of life for them.
I always have fun at an AAKP event. How could you not have fun? You're with people who understand completely what you and your family are going through. So it's not just for patients, AAKP. AAKP should be for the family of patients, because when a patient has kidney disease, the family has kidney disease.
Belonging to an independent advocacy organization like AAKP gives me the confidence that I can represent them and people living with kidney disease to represent them honestly.
Our objective over the coming decade is to reach people around the globe and not just limit it to the United States, because kidney disease is a universal disease.
They encourage patients to be the voice for their care and treatment. And I don't see that as much in other organizations. And I feel like that is so necessary for patients to feel like they have a voice and they can make change in regards to their care and treatment.
I think the AAKP, by being a patient-oriented group, impacts not only the medical devices, but pharmaceuticals and pretty much anything that's to do with the patients, because those companies will respond more to a patient than they will to a doctor, I think.
It's important to be a patient advocate because to whom much is given, much is required. I was given this gift of life back in 2008 by my donor, Leanne, rest in peace. She was a deceased donor. So now, if I can use my voice and use my platform and influence to impact lives, and my favorite word, why not? And why not become an organ and tissue donor today?
We spend a lot of time here, particularly in DC, in the nation's capital, talking with staff, with the legislators, and trying to help them understand exactly what the patient perspective is on anything that's kidney or renal related. It's a great honor to be able to do it. Our numbers are growing, and part of our strategy is for them to understand that we will come and visit and talk with them, and we represent the patient voice, and we want that to be heard, and that's how we do it.
People around the world who are sick and suffering with kidney disease need a voice of optimism, they need the tactics, and they need the reinforcement from fellow patients here in the U.S. to do what they do and demand a change in the status quo. And we fully intend to arm patients around the world with the tools they need to be more vocal with their governments, regardless of the ideology of their government, and to demand solutions and to defend private sector companies and investors who are willing to get into this space and deliver more innovation for patients.
AAKP opens the door so that it broadens the whole horizon. You're one person. When you belong to AAKP, you suddenly become a tribe.
Welcome to today's HealthLine webinar, the latest in our COVID-19 series, Coronavirus and Transplantation, Learn the Facts, Save a Life. This webinar is hosted by AAKP's Center for Patient Education and Research in partnership with our strategic allies in the fight to expand patient access to kidney transplants, the American Society of Transplant and its Power to Save program, and the American Society of Transplant Surgeons. I would also like to give a special thank you to our webinar sponsor, Eurofins Transplant Genomics. My name is Diana Kleins, and I serve as the Executive Director for the American Association of Kidney Patients. It's my pleasure to host today's webinar and provide valuable information to you alongside our partners at AST and ASTS. AAKP is the nation's largest independent kidney patient organization, and we are vigorous advocates for the right of patient consumers to choose the therapies that align best to their personal aspirations and life goals, including kidney transplants and home dialysis. AAKP's HealthLine webinar program falls under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of the treatment and protection of patient lives, and we work to ensure that patients remain at the center of all kidney research and policy that impacts lives. This includes federal policies and private sector innovations that impact healthcare services, assistance programs, and access to new products and services. This is especially true during national emergencies such as the coronavirus pandemic, because kidney patients are considered among the most vulnerable populations. At this time, I'd like to introduce AAKP's president, Richard Knight. Richard is a former in-center hemodialysis patient who received his kidney transplant 14 years ago. Richard?
Thank you, Diana. First, I would like to thank everyone who has shown a concern for kidney patients and the threat of the coronavirus who joined us on this call today. Second, I would like to thank Dr. Bloomberg, President of the American Society of Transplantation, and Dr. Ratner, President of the American Society of Transplant Surgeons, for their time and expertise. AAKP is proud to have both AST and ASTS as our long-term strategic partners in addressing transplantation challenges. AAKP is also honored to serve as a participant in AST's Power to Save initiative and joint efforts of ASTS and AST in improving transplant metrics. We're also pleased that AST and ASTS have been vocal allies with AAKP on the need to expand kidney patient consumer choice, especially access to organ transplants, and our shared efforts to fight disparities in transplantation among minority populations. AAKP has recently participated in meetings hosted by AST and ASTS, where I had the pleasure of serving on panels representing the patient's perspective in transplant-related issues. In short, Dr. Bloomberg and Dr. Ratner are true allies of AAKP, of which we're very appreciative. AAKP arranged and hosted today's webinar because for 50 years, we have served as an independent voice of patients, and we take our role in educating patients and providing insights into their concerns to policy leaders very seriously. The coronavirus is a serious threat to all Americans, especially those with underlying health conditions who are immunosuppressed, like kidney patients. I know this threat well. I'm a kidney transplant recipient who was self-quarantined on the advice of my medical team back on March 6th for over 14 days after being exposed to a person with confirmed case of COVID-19. I pray for everyone who is or who may face the threat of this disease. Many of those who have registered for this program have sent in some great questions for Dr. Bloomberg and Dr. Ratner, which they will answer at the end of their presentation. Now I have a favor to ask. I'm asking all who are listening and watching to stay connected to AAKP and to share your involvement in our online efforts. Because although our reach is growing, we believe we need to educate more patients on how serious this virus is and the threat that they face. I will now ask my fellow transplant recipient, AAKP Chair of Policy and Global Affairs, and immediate past president, Paul Conway, to talk about our survey research that led in part to today's program with AST and ASTS. Paul?
Hey, thank you very much, Richard. And thank you, Dr. Bloomberg and Dr. Ratner, for joining us today. AAKP has a Center for Patient Education and Research. And in that center, we have built very substantial capacities for survey and polling data. And at the outbreak of the coronavirus pandemic in the United States, what we chose to do is go out and survey the patient population to see what they knew
and where they were getting their information from and what their most trusted sources were. And not surprisingly, patients view their doctors as the most definitive source of information when it comes to impacting their lives and their families. What we were most concerned about is where we saw deficits of knowledge, especially among the patients, in terms of how the disease could impact them and how they were learning from different sources what to do to defend themselves. You can see 4 quick slides here that have results from our flash surveys. One that talks about the credibility and trust that patients have with their doctor, no surprise to us. The second up on the right-hand side shows you the perceived vulnerability that transplant patients and kidney patients have, especially in light of the coronavirus. 97% believe they're vulnerable. In the lower left corner, you'll see a slide that indicates how many patients have been educated or reached out to with telemedicine. And it's a little bit more than half have not had a discussion about telemedicine and engaging their professionals. On the lower right-hand side, you'll see the number of patients who have indicated they've not received communications from their medical teams. So when we look at this, there are 2 ways to look at this data. One, oh my gosh, there's a problem here. And the other part of it is the more optimistic side, in which AST and ASTS have joined us today, which is educating patients on what they need to know and the types of questions that they should proactively be reaching out to ask their transplant teams, because conversations are never passive. We understand as patients, we have to be proactive and engage. And that's what this webinar is designed to do today. I'd like to give a special thank you to AST and ASTS on behalf of all of the AAKP board and Richard and all of us who have worked so long on Capitol Hill, because our partnership with AST and ASTS has been critically important to secure additional leave for living kidney donors through the Family Medical Leave Act. And also, as a team, we work very aggressively to try to get immunosuppressive drug coverage through Congress, and we're working on that again. But we will be reaching out to those who are listening to engage you in these efforts and surveys in the coming future, because we use survey data to inform elected officials and professional staff in the federal executive branch on what transplant patient concerns and kidney patient concerns are. Thank you, Richard.
Thank you, Paul. I'd now like to introduce our first guest speaker, Dr. Emily Bloomberg. Dr. Bloomberg is the president of the American Society of Transplantation. She is a transplant infectious diseases specialist and the director of the Transplant Infectious Diseases Program and the Infectious Diseases Fellowship at the University of Pennsylvania, position she's held since 1999 and 2005, respectively. Dr. Bloomberg's academic interests are focused on infectious disease complications in transplant recipients and candidates. She is especially interested in donor-derived infections and viral infections, including HIV and CMV. Dr. Bloomberg, thank you so much for sharing your time with us. We know how busy you have been serving on the front lines. We appreciate you joining us today. I'd now like to turn things over to you.
Great. Thank you so much, and thanks to AAKP for allowing me to share some information about COVID-19 with you today. I'd like to start with sharing with you some information about the infection itself. COVID-19 is caused by a coronavirus that was newly discovered and first identified in Wuhan, China in December 2019, hence the name COVID-19. A cause of flu-like respiratory illnesses, it was initially described as something that spread from person to person. While originally it was thought that this infection was confined to this specific area in China, it has rapidly spread throughout the world and is now present in all 50 states in the United States. Many of our patients are trying to figure out if they're at risk for COVID-19. Initially, this risk was felt to be associated with specific travel to an area where there was COVID-19. And this is still the case. But it turns out that anyone who has had close contact with someone with COVID-19 is at risk. And most importantly, now in many areas of the United States where COVID is present in the community, If COVID is present in your community, you would be at risk for this infection. But risk doesn't necessarily mean that you are infected. And in fact, there are a number of things that you can do to protect yourself on a daily basis to prevent infection with COVID-19. One of the most important things is to avoid close contact with people who are sick. If you yourself are sick, you want to be sure to cover your cough or sneeze by coughing or sneezing into your sleeve, into your elbow, or into a tissue, which you promptly discard. If you're sick, you should not be out in public and you should be staying home. At all times, avoid touching your eyes, your nose, and your mouth, as these are the areas where COVID-19 can enter your body. Remember, it's important to clean and disinfect frequently touched objects. That includes things like cell phones, computer keyboards, doorknobs, handles, things that you might be touching and others might as well. Recently, there's been a lot of confusion about the use of masks. At this time, the CDC does not recommend the use of surgical face masks for people who are well. Rather, it's recommended that cloth face coverings be used. And if you want to learn how to develop your own acceptable cloth face covering, you can simply go on the CDC website, and they have detailed instructions for making your own acceptable cloth covering. You want to make sure you wash your hands frequently. Typically, we recommend soap and water, washing your hands for a minimum of 20 seconds. But an alternative would be to use an alcohol-based hand sanitizer that contains at least 60% alcohol. There are additional things that are strongly recommended. At this time, we think one of the most important things we can do to control this infection is to participate in what's called social distancing. In other words, staying away from people. So as much as possible, you'd like to stay within your own home. If you do have symptoms, or if you know somebody with symptoms of COVID-19, they should definitely be wearing face masks when they're around other people. I mentioned how important it is to do frequent hand washing and also to use the cloth face covering that it's recommended by the CDC when social distancing is not possible. We think that it's important to stay home as much as possible, and for that reason, we recommend frequent trips to the pharmacy. One way that you can do that is to contact your doctor to ask about getting an extra supply of your regular prescriptions to have on hand. You want to also be sure that you have all your over-the-counter medicines and supplies, for example, things like tissues, on hand to treat fever and other symptoms. And at this point, the preferred medicine for treating fever is Tylenol acetaminophen. You should try, to the best of your ability, to have enough household items and groceries on hand so that you can be prepared to stay at home for a period of time and not shop frequently. Whenever possible, you want to avoid crowded stores. And if you are a transplant patient especially, or somebody with underlying kidney disease, and you have somebody else who can shop for you, I would encourage you to do so. We get a lot of questions about what kind of mask is the right mask. You've probably heard a lot about N95 masks. These are special masks used for healthcare professionals who are on the front lines taking care of patients with COVID. They should not be worn when out in general public by the general population. Why? For one thing, they may not be worn appropriately and may not even be protective. To wear an N95 mask properly, you need to be fitted for it to ensure that it will seal appropriately. And so we do not recommend that the public wear N95 masks. Additionally, in order to protect the healthcare force who is at the front lines, especially given shortages in these masks, we are really trying to reserve them for those most in need of using them to protect themselves when they're taking care of patients with COVID-19. I'm sure many of you are familiar with surgical masks, such as those that are commonly seen within hospitals or doctor's office waiting rooms. These are recommended for community use to prevent spreading germs to others when you're coughing or sneezing or have infection. But remember, if you are infected, we really don't want you out in public at all. They do not 100% prevent anybody from getting any illness from other people. But one of the things they may do, which a cloth face covering could do also, is prevent you from touching your mouth or nose with your hands. As I mentioned before, last Friday, the Surgeon General recommended that the public use cloth face coverings when out in public. These need to cover both the face and the nose and the mouth to be effective. And the less you can see through it, the more effective it will be. Remember that every time you use it, you need to launder it after wearing it outside. Some materials that have been used are bandanas, pillowcases or cut sheets, or t-shirts. And actually, Dr. Adams has a very nice clip on the CDC website that shows you exactly how you can use those masks. We get a lot of questions about going to work, and this depends a lot on what you do for your work. We recommend to our patients that they work from home whenever possible to limit potential on-the-job exposures. But for those people who need to actually go to their work, we ask you to consider, what's the work environment? Are there a lot of people around you? Would you be exposed to potentially contagious individuals? And is there any opportunity to work from home instead? If you must go to work, we'd like you to try to make sure that your environment allows you to distance yourself from others and protect yourself while at work. If you have concerns about your work environment, you should talk to your provider to determine how best to make it safe, or perhaps to provide a note to excuse you from on-site work if that's a possibility. We're asked often how somebody would know if they have COVID-19 infection. The first thing I want to make sure you are aware of is that the symptoms vary tremendously from person to person. Some people have minimal to no symptoms, maybe a little stuffy nose. In most cases, it resembles a cold or the flu, where people typically have fever, they feel achy, and they have a cough. Recently, we've appreciated the fact that some of our patients present primarily with stomach upset or new diarrhea. Some people even lose their sense of taste or smell. A minority of patients do get severe pneumonia and breathing problems, and this would require hospitalization. If you think you may have COVID, you should call your healthcare provider to discuss your symptoms. You should be certain to call 911 if you develop any of the following signs: difficulty breathing, lasting pain or pressure in the chest, new confusion or failure to stay awake, or a blue discoloration of your lips or face. If you need to be hospitalized, it is important that you call your transplant center for instructions. So assuming that you don't have any of the emergency symptoms, but you're concerned about some worsening of symptoms, you should talk to your transplant center or your primary care provider, for those of you who are not transplant patients. If you have COVID-19, you should be aware that at this time, there are no specific medications that are routinely used to treat COVID-19. And in the vast majority of patients, most of the treatments that we're using are aimed at treating the symptoms primarily. Now, you've probably heard a lot on the news about medications that are being used to treat COVID, but you should be aware that most of these are being used either as part of studies or for compassionate or off-label use. And you should not immediately just start taking any of them on your own, as some of them that might become available would potentially have side effects that may be important for you to be considered for before you start the medications. Please call your provider to determine the most appropriate management of your infection. And it's especially important that you not stop any of your regular medications without talking to your provider first. If you're a transplant patient, this means your immunosuppression medication should not be stopped unless your provider recommends that. What about if you learn that you've been exposed to COVID and you feel fine? The first thing you want to do is you want to let your transplant or your primary care provider know that you were exposed. You should definitely separate yourself from the potential contact. And if possible, if it's somebody living in your home, it would be best if you stayed in different parts of your home. Wash your hands frequently with soap and water or use a hand sanitizer. Remember to avoid touching your eyes, nose, and mouth with your unwashed hands. Try to the best of your ability to avoid sharing household items with the infected patient. And if you can't do that, it's especially important that you clean all those high-touch surfaces frequently, including counters, tabletops, doorknobs, bathroom fixtures, toilets, phones, keyboards, and tablets and bedside table. And you should be doing this at least every day. All laundry should be washed thoroughly. Now, many of you may have upcoming doctor's appointments, or you may be in the midst of dialysis sessions. And it's important for you to recognize that your provider's first priority is the safety of you. And for that reason, in many cases, individuals may be told that their in-person visit is going to be exchanged for a phone or video visit. Your provider will let you know what type of visit is best for you. If you are told to come in for an in-person visit or you're going to a dialysis center, be sure to ask what precautions you should be taking if they don't tell you about them up front, because there may be some extra steps that'll be involved in making your appointment. For many of you, you may be due for lab work. And in some cases, your center may recommend going to your local lab or having a home blood draw. If you do need to go to a lab, be sure to make an appointment before you go so you can reduce your wait time. And while waiting, make sure to stay 6 feet away from others at all times and wear a face covering. Let's say you've gotten COVID-19. Please do not leave your home if you're feeling better until your provider says it's safe to do so. If you're a transplant patient or a patient on other immune suppression, you may remain contagious longer than other patients with COVID-19. So we want to make sure you do not transmit the virus to others. So please be in touch with your provider to find out when you can safely leave your home. As a general rule of thumb, all of your symptoms should be fully resolved, and there'll be a waiting period of anywhere from 3 days for someone on no immune suppression to longer for people who are on immune suppression. So with that, I'll conclude my remarks and be happy to take questions at the end of this. I hope you all stay safe and stay well. If you have any questions, the American Society of Transplantation has posted and regularly is updating some FAQs on our website, which is listed here at the bottom of this slide. Thank you.
Thank you, Dr. Bloomberg, for providing this important information. I would now like to welcome our next guest speaker, Dr. Lloyd Ratner. Dr. Ratner is the president of the American Society of Transplant Surgeons. He is a professor of surgery and director of renal and pancreatic transplantation at Columbia University. Access to organ transplantation has been Dr. Ratner's major academic interest. He has been a leading innovator in transplantation for over 2 decades. In 1993, he performed the world's first dual renal transplant. In 1995, with Dr. Louis Kosova, He performed the first laparoscopic donor nephrectomy and set the stage for its widespread adoption, which resulted in a profound increase in living donor kidney transplantation. Dr. Ratner has also made significant contributions in overcoming immunological incompatibilities that prohibited transplantation. Dr. Ratner, thank you as well for sharing your time with us. We appreciate how busy your schedule is as well and are honored to have your time today. I'll now turn things over to you.
Great. Thank you very much for that introduction. It's really my pleasure to be here this afternoon and to be able to share some of our thoughts and experiences about the current COVID-19 pandemic and its impact on the transplant world, and particularly access to transplantation. If you want to put a face to the voice, you can see on the left, there's a picture of me on a good day, professionally enhanced photographically, and of course my wife picks all my clothes. For most of my academic career, I focused on access to transplantation, and as you heard, made some well, I think were pretty important contributions. So I'm going to focus a lot of the talk today about how this pandemic is affecting access to transplantation, and also some of the challenges that we face with the COVID-19 pandemic. Next slide, please. So a lot of people think of transplantation as a single event, getting the surgery and getting the organ. But we tend to think of transplantation more as an entire continuum of care, which starts with, when patients initially get referred for evaluation at a transplant center, and then during the whole evaluation process, and eventually people get put on a waiting list, or they start looking for living donors, and we need to manage that waiting list. And then we have to find them the right organ, either from a living or deceased donor. Then we actually get to the transplant surgery. And then there's the whole care in and around the time of the transplant. And then obviously the patients who receive transplants need to get long-term care and to be on anti-rejection immunosuppressive therapy for the rest of their lives, as long as they have the functioning transplant. Next slide, please. So what I'll talk about, I'll give a couple of facts about COVID. I'm going to talk about what the American Society of Transplant Surgeons has been doing. I'll talk about some of the challenges that we face with COVID. We'll talk about the waiting list, the organ supply, both from how it's impacted the organ supply, both from deceased donors and from living donors. And then I'll also talk about the surgery and hospitalization, and then finally post-transplant care. Next slide, please. So the most important thing to know from our standpoint in terms of how it's affecting transplantation about the coronavirus is that this virus that's causing this current pandemic is a new virus, basically identified, about 6 months ago or less. So we don't know all that much, particularly about its long-term effects and prognosis. Because we don't know too much, there's very few publications that we could look at in the medical literature. And there's very limited data that's just been collected from relatively small number of places, some places in China, some places in Italy, and now we're beginning to get more and more information here in the United States. And I'm unhappy to say that I'm here in New York, which right now is the epicenter of this pandemic. It's like Dr. Bloomberg told you, it's a highly infectious virus. And what we've been seeing in terms of how it presents, even in our transplant patients, is we have a full panoply of symptomatology from patients who are infected but are totally asymptomatic, have no symptoms at all, feel completely fine, to those who are deathly ill, and even patients who wind up dying from it. Although it looks right now that for those patients who are symptomatic, because we don't know how many patients are really asymptomatic because of problems with testing, it looks like in the general population, about 3% of those who are sick wind up coming into the hospital and get tested, wind up dying. It may be a little bit higher in the transplant patient population. Now, you've heard a lot about it causing respiratory failure. In the sick patients, we're beginning to see problems with other organ systems as well, including heart problems, which could cause both heart failure and heart rhythm problems. We're seeing it cause kidney failure. And one of the issues that we're facing here at my institution is that of the sick patients who are in the hospital, particularly those that are in the intensive care unit, we're seeing probably about 30% of those patients have some degree of kidney failure, and we're actually running low on dialysis machines and dialysis fluid used for the machines that you just haven't heard about in the lay press. You hear a lot about the shortage of respirators, but now it's starting to be a shortage, at least in the hospitals, not necessarily in the outpatient setting, but in the hospitals, of being able to provide dialysis for patients. And it's also causing issues with blood clotting, where these people who are very sick with the COVID seem to have a lot more blood clotting or abnormal blood clotting, which could cause all sorts of problems, and may be the cause of the kidney failure that we're seeing with COVID. Like I said, New York is where I practice, is currently the epicenter. And in my hospital system, we now have seen over 100 transplant patients with COVID-19. And because all of this is new, and because we're in sort of the high numbers now, we're really learning as we go, which is distressing, because obviously we as medical professionals, we base our opinions on facts, on knowledge, and most of all on numbers and odds. So it's concerning to us that we don't know anywhere nearly as much as we would like to know. Next slide, please. So first, the ASTS response. Well, Dr. Bloomberg and I decided very early in this crisis that all our societies needed to work together, both internationally and nationally, and we really needed to try and speak with a common voice. And I have to say that Dr. Bloomberg has really been doing all the heavy lifting in terms of organizing both national and international societies and putting on webinars. And we've worked both with my organization, the ASTS, Dr. Bloomberg's organization, American Society of Transplantation, UNOS, the United Network for Organ Sharing, the Association of Organ Procurement Organizations, and a variety of other organizations, to both review the information that's presently available and to disseminate it in webinar formats, which we've had one webinar already, and we have another webinar coming up on Monday. In the American Society of Transplant Surgeons, we constituted a small group, which we call a strike force, to review the literature, make recommendations, and provide guidance documents for our members. The co-chairs you could see on the left of this strike force is Dr. Louis Tepperman, who's at NYU. So I'm sorry, he's at Northwell and on Long Island. So he's also in the thick of it here in New York. And Dr. Tim Pruitt on the right, who's a former president of our society and also a former president of UNOS, and is also a real expert in infectious diseases. So we're trying to inform our membership about patient safety and appropriate care. Also, very important, at least for us, is workforce safety, because if you don't have the staff to take care of the patients, then the patients aren't going to get taken care of either. With transplantation, there's a lot going on in terms of resources and logistics, and obviously there's some very specific things that have to do with surgical considerations. So that's how our society is trying to fill in some of these knowledge gaps. Next slide, please. So what are some of the challenges? Well, some of the challenges that we face are, and you've heard this from Dr. Bloomberg, more in terms of individual patients, but we in the transplant world are thinking about how does disease get transmitted, and can it or will it be transmitted from the organ donor to the recipient? And then also, with a large concentration of COVID patients in hospital environments, is the hospital environment the place where disease is transmitted? Second, we need to think about the impact that immunosuppression medication has in terms of increasing patients' risk. And what about how does that interplay with other high-risk conditions such as diabetes, obesity, and older age? And certainly we have lots of patients who are diabetic, obese, or older, or any combination thereof that are also on immunosuppression. Then, very importantly, we need to be thinking about what the hospital resources are, and do we have the adequate resources to take care of transplant patients when we're in the thick of this pandemic? And then, if we do transplant people, or people have been transplanted, how are we able to provide them with the appropriate post-transplant follow-up care, both in terms of office visits and also in terms of getting them to the office visits? And as you know from the AAKP, televisits or virtual visits are playing a larger and larger role in being able to provide that care. But just a word about the transportation. It's becoming increasingly difficult for many people to get transport. I'll just tell you an anecdote. A patient of mine called me last Saturday. I was actually out in the park with my dog, and she was sick and needed to come to the hospital. She lived in a county that didn't have any transplant centers, and we had to get approval from New York State to get her even a ride via a car service to get her to be able to cross counties and come to our center where we're familiar with her care and familiar with her case and familiar with her. So I spent over a half hour on the phone just trying to get this poor woman a ride to get to the hospital. I'm happy to say she did better, got to the hospital, got admitted, got treated, got better, and went home. And then, God forbid that people who have a transplant have a rejection during this pandemic. How do we treat the rejection, not so that we don't increase their likelihood of getting infected, or if they're already infected, how do we treat the rejection? And there's almost nothing known about this. We had one patient recently that was admitted, was totally asymptomatic. We tested him for was admitted for a rejection of his kidney transplant, a recent transplant from a living donor. We screened him for the COVID virus and he tested positive, although he was asymptomatic. And then it was, how hard do we push to treat the rejection versus and not be afraid that we're going to make the virus worse? So these are all things that we're thinking about in the transplant world. Next slide, please. What about the virus's impact on the waiting list? Well, the virus the pandemic is different in different localities at different times. Right now, we're experiencing a surge in New York. It's estimated that in a couple of weeks, it'll surge in Florida, let's say. So, we're doing different things at different pace here in New York than other people are. So, transplant centers will respond based on where they are and what their resources are relative to the surge in COVID cases. Now, when we're in the thick of the surge, as we are in New York, transplant personnel may need to be redeployed to other areas of the hospital. So many of my colleagues are working in either the ER or in the ICUs. And some of the usual services that we could provide for transplant patients may not be available. So for instance, we have about 30 operating rooms in my hospital. 27 of those operating rooms have been turned into intensive care units and are not available for surgery. So we need to anticipate what the impact of COVID's going to be on the entire continuum of care. Sure, maybe we can get you in and do a transplant and get you transplanted, but how's that going to affect your in-hospital care? How's that going to affect the long-term care? And is this necessarily the right time or the right place to do a transplant during the pandemic? And those are all things that your transplant centers, your transplant surgeons and physicians are thinking about during this pandemic. So some transplant centers have either largely or completely ceased doing transplant, again, taking those above things into consideration. Now, they may still be doing evaluations and follow-up via televisits, as we are in my center. Some may have largely curtailed doing transplant, but may do selective cases. So we need to weigh the risks at this time versus the potential benefits. So some of the people that we may be transplanting are people who have lots of antibodies, and it's difficult to find them a match. So we find the 1 in 10,000 kidney that matches them. We'll take that and we'll transplant them because it may be their only shot for a long, long time. Or there may be patients who are doing poorly on dialysis. So again, we're constantly doing this risk-benefit weighing out for the individual patients and also for what's going on in our individual hospitals. Next slide, please. So what about the organ supply? So let's first talk about living donors. Well, obviously, living donor transplantation for a variety of reasons is the best form transplant. You don't have to wait on the waiting list. The organ usually works right away. It usually lasts longer. Everything is better with a living donor. But our primary concern has to be living donor safety. So we're taking someone who's not sick and we're putting them through a major operation for no direct benefit to themselves. Okay, so we have to weigh out the living donor safety in terms about what's their risk of getting infected if they come to the hospital, or if they have some complication or need some additional resources that may not be available at the time in the hospital. Then we also have to worry about, is the donor going to be able to is the donor, let's say if they're asymptomatic, would they transmit the disease to the recipient if they have COVID but are asymptomatic? So we also have to be thinking about what the availability of testing is. We know that the testing is not as readily available as we would like it. It's improving, but still, there's still big challenges with being able to get everybody who needs to be tested. Then, depending on how the test is done, which test is done, some of the tests are more reliable than others. And about 30 to 40% of the time for the most common test, there's there could be false negatives. So in other words, tests could turn up negative, say you don't have virus, but the person really does. So I'd say that most centers in the United States have ceased performing living donor transplants for now. Not all, but most. And I think, again, the primary concern is the safety of the donor, and also the secondary concern, safety of the recipient. Now, what about the organ supply in terms of deceased donors? Well, since many of the hospitals are becoming overwhelmed with COVID-19 positive patients, many of the deaths that we're seeing, they get referred to the organ procurement organization as potential organ donors, are COVID-19 positive. So we don't know if it's safe to utilize those transplants, and for fear of those organs, for fear of transmission of disease. And so I think most people feel that the most prudent course of action is to not use organs from COVID positive donors. And we're also seeing, because the hospitals are primarily taking care of COVID positive patients now, that the organ procurement organizations are not getting a lot of referrals from other types of organ donors. So again, the same questions with the living donors. What about, the disease transmission from asymptomatic donors, the testing available? Most organ procurement organizations now throughout the United States are testing every single donor, but then it gets back to, again, the question of the reliability of the testing, and if there are false negatives, is it worth taking those chances? Then we also face logistical and transportation concerns. We have to get the procurement teams out to the donor hospitals. Many of these teams are facing travel bans. So it's a lot more complicated than it was just a few weeks ago, when we didn't have to worry about the pandemic. But because the virus is impacting areas differently, some areas may actually have an increased organ availability because they're not competing as much for the organs, and they're going ahead and transplanting full speed ahead, whereas other areas, they may not, they have very few organs for transplantation because the donor supply is down. So it's very, very variable, and it's constantly changing, as Dr. Bloomberg said. Unfortunately, because of this virus, many of these donors may wind up being underutilized, which I'm sad to say. Next slide, please. So similar to transplantation, the organ procurement process is a continuum of care. So just to illustrate the point that, it's not like you're able to take a supply off the shelf. Like, if you need a hip replacement, those are manufactured, they're sitting on the shelf, you can get them. With organ donors, it's a very complicated process to get the organs. Next slide, please. So what about the surgery and the hospitalization? Well, as I said before, we are always looking to say whether the benefits outweigh the risks. And the way we think about this are, what are the opportunities to get a transplant in the future? What's the risk of dying without a transplant? And what will be the risk of contracting COVID, either as an outpatient or in the hospital? Does the hospital have availability to have COVID-free facilities? Are the ORs and the staff available? Then we're asking questions like, well, in the face of the virus and the risk of infection, what's the best type of anti-rejection medications to use? And then if, God forbid, the patient develops a complication, do we have the ability to care for those complications? And do we have the ability to provide appropriate follow-up care? And the way I think about it, if you look at the picture on the right, that's the famous Walenda family, who's a whole family of circus performers, of tightrope walkers. And they classically, they've done this for generations, but they classically have performed without a safety net. And every now and then, every couple of generations, they have an accident and a couple of them wind up falling and dying. So we don't want to be operating on people without the appropriate safety net in place unless we absolutely have to. So it's just all these sort of things are what your transplant doctors and transplant programs are thinking about as we address this pandemic. Next slide, please. So post-transplant considerations, again, what type of anti-rejection therapy should we be using? What are the logistics of the follow-up care? And what do we do if we have a patient that develops COVID-19 post-transplant? And like I said earlier, we've seen now at our institution over 100 transplant patients, about half of which are kidney transplantations, in the entire spectrum of disease. Some have tested positive but are asymptomatic. Some have mild symptoms and are remaining at home. Some are ill enough that they require hospitalization. Some have gone to the intensive care unit and required life support. And unfortunately, we've had a couple of patients that have died. Then we're also asking, when we first see a patient that may or have COVID, or has COVID, will the disease progress or not? And we just don't know what are the factors that determine whether someone's going to have a mild illness and get better from it, or whether they're going to progress. So it's really important that, if you have any symptoms, that you keep close contact with your transplant center and transplant doctors. And then what to do with the anti-rejection therapy in the COVID positive patients. And in general, we've been reducing the immunosuppression. How much, which agent to reduce is all up in the air. And hopefully we're beginning to collect data on that now. But there's, like I said initially, there's very, very little to guide us in doing this. Well, we know that sometimes when people get really sick in the intensive care unit and have to be put on respirators and life support, that they sometimes get secondary infections. We have to deal with that. And then, I told you before about the renal dysfunction and the heart disease that people are getting with COVID. We don't know whether that's going to have long-term lasting effects or not. And just because there isn't enough track record with this virus to be able to tell us. And then finally, like I told you before, we've had the patient now who had rejection, and what's the best way to treat them if it develops. So there's more unknowns than known. Next slide, please. So, and just in conclusion, here in New York, although we're in the epicenter, it looks like we're beginning to have, reached its peak and plateauing. For the last couple of days, we've had more discharges from the hospital of COVID-19 patients than admissions. So that's all a good sign. And I'm optimistic that, again, because so many people are working so hard and well together, that we're beginning to get the data that we need to answer all these questions and to get back to normal at some point in the hopefully not too distant future. So I'll end there. I would like to once again thank the AAKP for inviting us from the ASTS and me personally to participate in this discussion, and be happy to answer any questions.
Great, thank you, Dr. Ratner. We will now take a few questions. I think we have time for a couple. If you have a question, please submit it via the chat feature located at the bottom right of your screen. And it looks like our first question is from Megan from New York. What is the risk of losing a transplanted kidney if you are infected with the COVID-19?
That's a great question. And I think it depends, again, on how sick the person gets. So like I said, most of the patients that we're seeing and following have some fever, maybe a little bit of shortness of breath, which then necessitates them getting admitted into the hospital. And most of them ultimately do well and get better and go home. The sicker patients where we have to do more dramatic reduction in anti-rejection medication tend, have a much greater chance of losing function of the kidney and losing the transplant. Maybe Dr. Bloomberg would share some of her experiences.
Yeah, I think that we've seen some, decline in kidney function at the time of the actual infection. What we don't know yet is how much recovery there might be afterwards. It's important to recognize that people with severe infections often take a hit to the kidney where they're not, their kidney function declines at the time that they're so sick, and that sometimes days or weeks or even months later, their kidney function does improve. And so I think certainly we're all concerned about the fact that some of the really sick people are having problems with their kidney function, but we don't know what they'll be like after they've fully recovered in some of these cases. And I think it's probably too early to say what to expect, but we are concerned about that possibility in the sickest of people, especially.
And the second question kind of piggybacks on that a bit. It's from Damien from Texas. If infected with coronavirus, would immunosuppressant medication need to be stopped or lowered to effectively treat the virus? And if so, when is that determination made?
That's a great question. And I think a lot of people are especially interested in this because there are some medicines that have an impact on immune function that are even being used in some centers as part of the treatment for people who are really sick with the infection. We would not recommend that anybody stop or change their immunosuppression dosing unless it's specifically recommended by the transplant doctor. I think it's important to recognize that just stopping something without a plan may cause acute rejection of the kidney, and that could make things even worse. And so while under an observed setting, your doctors may decrease your immune suppression, we certainly would not want you to take that on yourself. And all changes in immune suppression should really be done in collaboration with your transplant center and transplant providers. Lloyd,
Yeah.
what have you been advising your patients?
Yeah, there have been, it also depends a lot on how far out from the transplant someone is. If they're recently after transplant and are on higher immunosuppression, and are certainly at higher risk for rejection, we may not lower it as much as someone who's on minimal immunosuppression and just lower that a little bit. There's so many variables that come into play, but that's why it absolutely, like Dr. Bloomberg says, has to be done under physician supervision and shouldn't be done by, a patient themselves.
I think we have time for two more questions. If a person is infected with coronavirus and passes away and is an organ donor, can or will their organs still be used?
Yeah, I think Go ahead,
Go ahead.
Emily.
Oh, I was going to say, no, we would not. We don't actually know much about what coronavirus does to organs other than the lungs, but they have been able to recover the virus in stool specimens. And so we would certainly be concerned about infection in the intestines. We also know that in people who are quite ill with coronavirus, there has been some impact on the heart and also on the kidneys. And while this may not reflect infection of those organs, it may be from a different process. I don't think any of us would feel comfortable using organs from somebody who died of coronavirus infection.
Yeah, I think that's the consensus among most transplant doctors.
And our last question is from Melissa from Florida. If a person is infected with coronavirus and then recovers, will this impact their ability to be a living kidney donor?
That's a great question. I hope we get to that point really soon. There's, I'd say, zero data. And one of the questions that we don't really know is, well, there are a couple of things that we don't know. One is if they've recovered, is the virus dormant, and then, could it go to the, with the transplanted organ to the recipient? And so the other thing we don't know is, if people have had the virus and what their immune response is like if they're exposed to it again. So, and one of the problems we face is we don't even know who's mounted an immune response and has antibodies to the virus. So, they're beginning to do antibody testing now. And if it's like many other viruses, hopefully those antibodies will be protective. So we may be able to say someone who's a living kidney donor could, and has had the COVID virus, could only donate to someone who has antibodies already and is immune to the virus. But there's no data on any of this yet. This is just sort of extrapolating from what we know from other viruses.
Yeah. And I think Lloyd makes a good point, which is if this virus behaves like other coronaviruses, we don't think it will remain like in sleep, latency in the body, but we are still pretty early in our understanding of this infection. My guess, if it's similar to other coronaviruses, that after some period of time, assuming that the kidney function wasn't impacted by the infection, that people could go on to donate safely. But we still, as Dr. Ratner said, we still have many unknowns and a lot to learn. And so I think we'll need a period of time to understand more about this infection before we would recommend using that individual as a live donor. But we're learning so much so quickly with this infection that anything we say today, potentially we could learn a lot more about in another 3-4 weeks that might better inform our decision making.
Well, thank you both for your responses, and thank you those participating for submitting questions. If you have a question that we did not get to during today's webinar, please reach out to us at info@aakp.org, and we'll work with today's speakers to provide a response. We hope you found this webinar informational. I would like to share a few slides about additional AAKP resources and services that may be of interest to you. If you are not already a member of AAKP, we encourage you to join. AAKP offers free membership to patients and their family members, as well as living donors. To become a free member, join online at aakp.org or by phone at 800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo of kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our printed bi-monthly magazine, AAKP Renal Life. We also invite you to follow us on our blog and social media for all the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients, family members, and caregivers. By visiting our website and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order online, by phone, or to download. AAKP holds a number of events throughout the year, and these events are live streamed and recorded. Please visit the YouTube channel to watch presentations from our Global Summit on Kidney Innovations hosted in partnership with George Washington University, our annual policy summit, and our annual national patient meeting. To view upcoming activities, visit our website and click on the Programs and Events tab at the top of the page. I'd like to remind everyone that this webinar has been recorded and will be made available. We'd again like to thank today's speakers, Dr. Bloomberg and Dr. Ratner, for sharing with us the most up-to-date information on COVID-19 and how transplant patients, as well as those waiting for a kidney transplant, can protect themselves. For more patient resources on COVID-19, to listen on demand to today's webinar or our previous webinar AAKP hosted regarding COVID-19 with our federal partners from the Center for Disease Control and Prevention, please visit the Coronavirus Resource page on the AAKP website. There's a link directly to this page on our home screen. I'd like to again thank today's webinar sponsor and share a special message from our friends at Eurofins Transplant Genomics on their commitment to the kidney patient community during this time.
Hello, my name is Stan Rose. I'm president of Eurofins Transplant Genomics. As a kidney transplant recipient myself, I understand how difficult it is for all of us to adhere to our normal testing schedules right now. None of us really want to leave our homes if we don't have to. Well, Eurofins US Clinical Diagnostics also understands. That's why, to address the needs of kidney transplant recipients during this pandemic, we are now offering home collection of samples for the TrueGraf blood gene expression test, track cell-free DNA analysis, BK, CMV, and coronavirus assays, and many other standard clinical chemistry tests, such as serum creatinine. Remote sample collection will enable your physicians to continue with your regular testing schedule while avoiding in-person visits. Eurofins is proud that we can provide comprehensive testing solutions to help patients maintain healthy kidneys during this very difficult time. Take care, everyone.